Hello, I'm Adrian Gowdy, and in this lecture we're going to discuss pericardial effusions and cardiac tamponade. So let's start with a quick revision of the anatomy of the pericardium. There is the visceral layer, which is a serous membrane which attaches to the surface of the myocardium. And then there is the parietal layer, which is a fibrous sac in which the heart resides. The pericardium extends 1 to 2 centimetres up the great vessels and reflects around the pulmonary veins. In terms of its function, it fixes the heart anatomically and prevents excessive motion during changes in body position. The small amount of fluid that normally resides between these two layers reduces the friction between the heart and the other organs. It provides a barrier against infection, and it maintains the hydrostatic forces on the heart. Now, it's important to understand the physiology of the pericardium when we start to talk about tamponade. Respiration affects interthoracic and intrapericardial pressure, and in a normal person, the pericardial pressure will oscillate from -5 to +5 centimetres of water. The other thing to remember about the pericardium is that in the short term, it creates a fixed volume within which the heart resides. Over longer periods, the fibrous sac can gradually distend, but in the short term, it's fixed. And this results in a linked variation in filling between the right and left ventricles. So this table outlines the changes that we see during normal breathing. That is, a patient who is spontaneously breathing and is not on positive pressure ventilation. During inspiration, the intrathoracic and intrapericardial pressure reduces. As a result, the trans-tricuspid flow and right ventricular stroke volume increases, and conversely, the transmitral flow and the left ventricular stroke volume decreases. If you want to think about it as blood being sucked into and pooling in the lungs, this will help you remember what happens to blood flow through the right ventricle, which increases with inspiration as the blood gets sucked into the lungs, and through the left side of the heart, which reduces as that blood sits and pools into the expanding lungs. With expiration, the opposite happens. More blood flows out through the left, and so there is increased transmitral flow, but there is reduced right-sided flows because of the increased intrathoracic pressures. Now, normally in somebody who's breathing with the normal amount of pressure, this will result in blood pressure variation of less than 10 millimeters of mercury. Now, just to remind ourselves of the multitude of causes of pericardial effusions, here's a fairly comprehensive list. The commonest things we tend to see for hemopericardium, trauma and malignant disease, for a non-bloody effusion, inflammation, pericarditis, lupus, renal failure, and hypothyroidism. In the setting of an acute myocardial infarction, don't forget Dressler's syndrome, but if there's blood in there, then that can be a sign of a free wall rupture. So on echo, what do we actually look for? Well, the pericardium itself is bright and reflective. You cannot measure the thickness unless there is fluid on both sides. But fortunately, most of the time we aren't really interested in measuring the thickness, although some people like to if they're considering pericarditis. But for this course, with considering the effects in the hemodynamically compromised patient, you don't need to worry about doing that. Now, effusions appear as echo-free spaces, and they appear as an echo-free space whatever mode you're using, be it two-dimensional or M mode, in whatever view you're using. But don't forget that if it is a hemopericardium, if there's blood, then blood clots, just like they can in the abdomen, can appear as echogenic masses. and some inflammatory collections may also have echogenic debris in them from the fibrin strands. So here is an example of a hemopericardium. This is from an aortic dissection. We can see here, this is a subcostal view, here is the right ventricle. We see the echo-free space of the fluid, but as well, we see this echogenic mass flopping back and forward on the surface of the right ventricle. And this is actually blood clot that has formed on the surface of the right ventricle. Now, one of the things we need to be careful of is that we don't misdiagnose a pleural effusion as a pericardial effusion. Now, this is usually only a problem in the parasternal views. And one of the things you need to remember is that the pericardium runs up around the base of the aorta. And therefore, any pericardial fluid in that space has to taper up in front of the descending aorta. If you see fluid going behind the descending aorta, it cannot be pericardial fluid. It must be pleural fluid. Now, of course, in that case, you also then have to make sure that the patient doesn't have both a pericardial and a pleural effusion. A large collection that is seen behind the left atrium is likely to be a pleural effusion. A very large pericardial effusion, you will get fluid in this position as well, but it will circumvent the whole heart as well. If you're looking on the apical four-chamber view, a loculated lateral pericardial effusion can be quite difficult to distinguish from a left pleural effusion. But in that case, once again, what we may do is swing the probe round further and have a look and see if the patient has a pleural effusion. The most reliable view for people to determine a pericardial effusion, especially for beginners, is the subcostal view. And in this view, it's very difficult to get a pericardial and a pleural effusion confused. However, don't forget that fluid surrounding the top of the liver, because at that point, the left lobe of the liver is usually adjacent to the heart. Fluid across the top of the liver has to be distinguished from pericardial fluid. So here's a diagram to outline what we're saying. Here we see the heart. Here we see a large fluid collection that's surrounding the heart. It's coming up and it's tapering at this point here. And here is the descending aorta. Now, sometimes you'll see what looks to be a small anterior effusion. Now, in most cases, this will not actually be a pericardial effusion. Why? Because fluid tends to collect posteriorly. It tends to follow gravity. So if it's just anterior, it is much more likely to be pericardial fat that is sitting anterior. And if you increase the gain on your machine, you can usually see some echogenicity to that structure. Fibrosis can give a similar appearance, and a thymus can also appear similarly. Rarely you may get an anterior loculated effusion, but it's actually very uncommon. As we mentioned, on the subcostal view, and we're going to emphasize this because this is the view you're going to be using most commonly, I think, you need to distinguish between fluid that's intraperitoneal, that's coming up over the top of the liver, and fluid that's around the heart. Now, if you're seeing fluid that's sitting on top of the liver that's intraperitoneal, generally this means that you've got a lot of fluid in the abdomen, and you will see it if you look in the other abdominal views. Subdiaphragmatic fluid tracks around the liver, whereas pericardial fluid tracks around the heart. So if you're not sure on the view, move your probe, sweep it across, see where that fluid goes. If you sweep into the right upper quadrant and the fluid continues all across the top of the liver and around the liver, then you know it's intraperitoneal. On the other hand, if you sweep and there is no fluid in the abdomen and on your other views you can see fluid that clearly surrounds the heart, then you know it's pericardial. So what do you do when you see a pericardial effusion? Well, the things you need to consider is, where is it? How big is it? Is there any loculation, in particular if you're going to consider draining it? And are there signs of hemodynamic compromise? So working our way through these. Usually fluid collects in the most dependent area. So in the supine patient, that means posteriorly. And the smallest amount of fluid you'll see is in the posterior atrioventricular groove. Now when we talk about the size, this is generally categorized as trivial, small, medium, or large. A trivial effusion is visible only in the AV groove, and it's only seen during systole normally. And this is the normal pericardial fluid. Here we have a subcostal short axis view, and where the arrow is pointing, here we have the liver, we have the left ventricle in a short axis view, the right ventricle triangular, and there's a tiny bit of fluid sitting here in the AV groove, and that's the normal pericardial fluid. A small effusion is defined as being up to 1 centimetre posteriorly. It may extend into other areas or it may not. Here's an example. Here we have the beating heart. We see the echolucent space coming here and a little bit behind. It's less than 1 centimetre all the way around. This is a small effusion. Moderate is defined as 1 to 2 centimetres at its maximal point and generally will be circumferential unless it's loculated. A large effusion is greater than 2 centimetres and you may see the heart swinging within the pericardial sac. Now I only go through those to give you a rough outline. You don't actually have to remember that because the exact quantification of volume is actually very difficult. And what's probably more relevant is that it really doesn't make any difference at all. It's clinically unimportant, the volume. What's more important is the hemodynamic effect. Here is an example of a large pericardial effusion coming all the way around the heart here. And we can see the heart swinging back and forward a little bit. In there we see the fluid coming up here and tapering in front. This is the descending aorta down here. Now it is important to consider whether an effusion is loculated or not. And the way we tell this is whether or not the effusion surrounds the heart. If it's a small effusion, does it follow gravity as we would expect? Or if it's a larger effusion, is it symmetrically distributed? And if it doesn't do this, then we need to assume that it's loculated. Now loculated effusions can cause problems because with their positions, they may be very difficult or even impossible to see, particularly with transthoracic echo. And because a small loculated effusion can have very significant hemodynamic effects, even though it does not surround the whole heart, if it's compressing just the atria, it may prevent adequate cardiac filling. And so the type of patient we see this most commonly in is in the post-operative patient, post-cardiac surgery, and anyone who's looked after these patients in ICU will certainly know that you cannot use echocardiography to exclude a small loculated effusion that may still be hemodynamically significant. So now let's discuss the hemodynamic effects. And what this comes down to, in particular in the hypotensive patient, is we are trying to decide, is there tamponade? Now it's very important to remember that tamponade remains a clinical diagnosis. But nevertheless, we know that Beck's triad, the classical signs of tamponade, are unreliable. They occur in only a minority of patients who have tamponade. But nevertheless, you cannot just diagnose tamponade based on echocardiography. And the other thing to remember is that tamponade, like most physiological processes, are not a definite yes or no presence. This is a continuum. As the pressure in the pericardium increases, so the hemodynamic effects will increase. The amount of the effects will depend on the amount of venous filling pressure and also the level of compensation that the patient and the heart is able to mount because of those effects. And so as a result, we will see a range of echo signs, and some of those signs we will see in patients who have got frank tamponade, and sometimes we'll see those signs in patients who are compensating and therefore don't look as though they are tamponading, even though they do have some hemodynamic effects. So let's discuss these in more detail. Now, the important thing we need to remember is that it is the pressure within the pericardial sac that causes tamponade. It's not actually the size of the pericardial effusion. The rate of formation of that effusion affects the pressure-volume relationship. The fibrous sac cannot expand quickly, so for example, if you have bleeding, then a small volume will give you quite significant hemodynamic effects. On the other hand, if it's an inflammatory effusion that has gradually built up, the fibrous sac may have very slowly dilated to be able to accommodate a large volume. And in fact, in a very large series of patients from the Mayo Clinic, patients with tamponade who had effusions that were not large was actually more common than patients who had large effusions with tamponade. So, as we've mentioned, echocardiography can suggest that tamponade physiology is developing, that there are some pressure effects happening. So, what are those? Well, if we think about the physiology of tamponade, the increased intrapericardial pressure results in the exacerbation of those normal physiological variations that we talked about earlier. As the pressure increases, it can exceed the passive intracardiac pressures, usually in the right atrium first, then the left atrium, then the right ventricular diastolic pressure, then the pulmonary artery diastolic pressure, and finally the left ventricular diastolic pressure. In general, the left ventricular wall is stiffer and it has a more active relaxation. So the left ventricular filling is relatively unaffected until very late in this process. Now that all sounds wonderful, but you don't really need to get too caught up in it. So this is how I think about tamponade. As the intrapericardial pressure increases, it reduces right-sided filling. This results in falling cardiac output. This will be most pronounced at the time when right-sided filling is least, in other words, during expiration, and will be least seen during inspiration. Now don't forget that in this state the heart rate becomes critical because this becomes one of the main compensating mechanisms for the falling stroke volume. So what do we actually see when we look with echocardiography? Well, this is the full list that you'll find in any of the echo texts. The IVC tends to be dilated and plethoric with reduced inspiratory variation. The trans-tricuspid peak flow variation is increased. Normally it's 25%. With tamponade, we get an exacerbation of these normal flow changes, and so it's more than 25%. The transmitral flow variation, which is normally 15%, increases, and so it becomes more than 20%. This is the flow variation between inspiration and expiration. We'll see right atrial collapse and with wall inversion. Don't forget the right atrium does constrict during systole, and so moving into the right atrium is normal, but actually inverting is abnormal. And we'll see this during atrial systole or late ventricular diastole. In early diastole, the right ventricle is at its point of lowest pressure, and so it will tend to collapse at that point. It tends to occur in the right ventricular outflow tract, and then as the pericardial pressures increase, the actual body of the right ventricle can be seen to collapse. If we measure the aortic and pulmonary flows, there is more than 10% variation with respiration. Now, that's the full list. A lot of these things you won't be measuring, and we don't want you to measure. So these are the things that are a lot easier to see, which don't actually require measuring actual flow rates and so forth. With the exception of a loculated effusion, you will generally need a moderate to large effusion before you'll start getting tamponade effects. Atrial collapse can be seen quite easily on 2D. As we've mentioned, don't forget the normal atrial contraction in systole. However, collapse through diastole or inversion, which is the easiest thing to see, is abnormal. Then there's the right ventricular collapse, and because these occur in different phases of the cardiac cycle, you'll often see a snaking appearance, something like somebody shaking a slinky or a sinusoidal wave that appears to be running across the top of the right ventricle. There is the loss of the IVC respiratory collapse, unless the patient is profoundly hypovolemic. And if this occurs throughout both inspiration and expiration, then you're talking about higher intrapericardial pressures, and you're talking about greater hemodynamic effects. Sometimes you'll only see this right-sided collapse during expiration, and it will disappear during inspiration. And that tells you that there is some effect, but it's not quite so great. And whilst you're doing this, don't forget to feel the patient's pulse and their peripheral perfusion and look at their blood pressure, because that will tell you how much effect this pericardial pressure is having on their cardiac output, which is the important end result. So here are some examples. Here we have a pericardial effusion, and here we can see this snaking appearance between the collapse in the right atrium and the right ventricle. We'll just show that again so you can see, and we have this rocking or sinusoidal effect between these 2 points. Here is another patient, and again we can see the right atrial and the right ventricular collapse. But in this clip, and we'll show it again in a moment, note how that effect disappears during inspiration. So at the beginning of we have collapse, and then we no collapse, and then collapse again as the patient breathes in and out. Now this was a patient who was sent to the hospital because of reduced exercise tolerance. When we saw him, he was lying comfortably at rest, he wasn't tachycardic, he had a normal blood pressure. And yet when we had a look, here he has significant both right atrial, right ventricular collapse. He's got a large pericardial effusion going all the way around. The heart is actually swinging back and forward. This gentleman had a formal echo, and he fulfilled every single criteria for echo. All his transvalvular flows and output flows were all above the normal ranges. And so his echo report said, this man has every sign of tamponade. But clinically, he was compensating. So that's important because it tells us 2 things. The first is, I don't have to rush in and drain this effusion immediately because he's compensating. He feels all right. But secondly, I know that it won't take very much for this man to be pushed over the edge to a point where he won't be able to compensate. And if anything further happens to him, he becomes a little bit hypovolemic, he develops an infection, becomes a little bit septic, somebody wants to give him an anesthetic, reducing his preload and afterload, anything like that happens, I will expect him to decompensate very, very rapidly. Now, just to touch on very briefly pericardiocentesis and how we use echo for it, I think these days we should almost always use echo to guide our pericardiocentesis. First of all, it ensures that there's actually an effusion to drain, because clinically we know we're not very good at diagnosing tamponade and pericardial effusions. We look in all the windows for the best position, and not just the standard windows. Move all around the chest until you find a point where you have a good depth of the effusion, a small distance between the skin and the effusion, and no intervening vital organs. You can also use echo to assist as you put the needle in. You can, if you think you're in the right place, and you won't be able to hold the probe in a position usually that you can see the needle, but with your probe looking at another window, you can inject a little bit of agitated saline. And if you're in the right position, you'll see the bubbles in the agitated saline spread throughout the pericardial effusion. And that can be quite helpful, in particular if you're aspirating blood-stained fluid and you're not sure if you're actually in the effusion or in another structure. Now, if we look at the results from the Mayo series, which looked at 1,100 pericardiocenteses performed, one of the things that you'll notice is that the standard anatomical landmark technique coming from a subcostal approach was only performed in 18%. And in all other cases, there was a better approach found using echocardiography. In that series, they had a major complication rate of 1% and a minor complication rate of 3.5%. This can still be, even with echo, a tricky procedure to perform. You use your echo probe to work out where your effusion is, what your angle of approach is going to be, but then you have to take your probe away because with the ribs, the spaces are very small, and so you may use the echo probe to try and assist from another window, but it can still be quite tricky. So in conclusion, echocardiography can be used to confirm the presence or absence of an effusion. It can be used to show whether or not there are any signs of hemodynamic effects from that effusion. But nevertheless, the diagnosis of tamponade still remains a clinical one. And finally, you can use echo to assist in guiding pericardiocentesis. Thank you, and I look forward to seeing you all on the course where we will discuss these concepts further. Thank you.